The next series of lectures that you are about to listen to will be focused on the cranial nerves. While the lectures have been broken up into two parts in your handouts, I'm going to be breaking them up into smaller units because I don't want you to be focused on this topic for too long of a period of time at one time. So I've tried to break it up to give you some natural break points where you can go do something for yourself, do something for your family, take a look at another course material, and then when you're ready, you can come back and continue. But remember, you can stop a lecture at any time. So if you are starting to feel that you're getting lost or confused, my suggestion would be to stop the lecture, do something else for a bit, come back and re-listen to the part that you already listened to a second time. And at that point, see if things are a bit clearer. The following are really good websites for helping you understand the location of the cranial nerves and their different parts. This is kind of like understanding the anatomy of the spinal cord. Where are the cell bodies for the lower motor neurons? Where is are the different tracks for carrying sensory information? Where are the different tracks carrying descending motor, upper motor neurons? And where does where do the sensory input enter into the spinal cord? So we needed to know all that in the spinal cord in order to understand our spinal cord injuries. And the same will be true in the brainstem. If you have this basic understanding of where we have the different cranial nerves originating and where their voluntary motor cell bodies are, where the upper motor neuron descending tracts are, where the different pathways are for the sensation, then you can understand the signs and symptoms of brainstem injuries. Pixelated Brain uses a combination of hand drawings as well as actual brainstem sections, and she does a nice job of coloring in different features so that they stand out and you can see them. The UW-Wisconsin website has a very nice website showing all hand drawings in black and white, so there's no color. But I think the pathways there are shown quite nicely. Now let's review and compare our spinal nerves with our cranial nerves. In the last box here, where we have our types of neurons, I'm going to be specifically referring in the spinal nerve column to those named peripheral nerves that you learned last semester. These would be the branches of the brachial plexus and the branches of the lumbosacral plexus, and then those dorsal and ventral rami that innervate the walls of the trunk. But in the first couple of rows, this is going to be speaking more to that spinal nerve where the dorsal and ventral rami meet to create that spinal nerve. So how many spinal nerves do we have? We have 31 pair total of spinal nerves, nerves that originate in the spinal cord. See if you can fill in the blanks on the right-hand column for the cranial nerves. How many pair of cranial nerves do we have? And where did the cranial nerves originate? Notice there are 3 exceptions. Cranial nerve 1 and 2 are going to originate elsewhere, as is the accessory portion of cranial nerve 11, the accessory nerve. That portion of the accessory nerve actually originates in the spinal cord in the upper cervical levels. Cranial nerve 1 and 2 are going to originate in an area by the brain. But for the remainder, they have a common origin, and I'd like you to see if you can fill in that blank. Ready for the answers? we have 12 pair of cranial nerves. The cranial nerves 3 through 10 plus cranial nerve 12 all originate in the brainstem. Now let's look at the types of neurons. And here I want to focus in the peripheral nervous system from the spinal cord, those named peripheral nerves that are branches of the brachial plexus and lumbosacral plexus and the dorsal and ventral rami. I'm not going to focus on the spinal nerve portion prior to the dorsal and ventral rami because that's going to be slightly different. I want to be thinking about now our named nerves out in our limbs and out in the walls of the trunk. In those particular nerves, we have two types of neurons all the time and one type of neuron some of the time, really the majority of the time. The types of neurons that we always find in those peripheral named nerves are somatosensory neurons and postganglionic sympathetic motor neurons. Most of our peripheral named nerves also contain voluntary motor neurons, our alpha and gamma lower motor neurons. You'll recall, though, that we have a few nerves that are sensory only. They do not have voluntary motor neurons in them, although they do have postganglionic sympathetic motor neurons to innervate the sweat glands or the blood vessels. Those would be nerves like our medial brachial cutaneous nerve and the medial antebrachial cutaneous nerve, or the lateral femoral cutaneous nerves. So those are those ones that don't have voluntary motor. They only have sensory component and autonomic motor. Going to our cranial nerves, there are 4 different types of neurons that a cranial nerve might contain. 2 of these would be similar for the spinal nerves. 2 of them are specific to only cranial nerves. Cranial nerves may contain somatosensory neurons, as our spinal nerves do. Cranial nerves may contain special sensory neurons. This is unique in that only the cranial nerves will have special sensory neurons. Cranial nerves may contain voluntary motor neurons, as do most of our spinal nerves. And again, unique to the cranial nerves, we have preganglionic parasympathetic motor neurons in some of the cranial nerves. So we have 4 different types of neurons that might be found in any given cranial nerve. We have 3 types of neurons that might be found in our named peripheral nerves coming from the spinal cord. Unique to the peripheral nerves would be postganglionic sympathetic motor neurons. Unique to cranial nerves would be special sensory and preganglionic parasympathetic motor neurons. Now let me talk about differences between cranial nerves and spinal nerves when it comes to voluntary motor control. The lower motor neuron cell body for a cranial nerve is located in a nucleus instead of in the ventral horn like it is for a spinal nerve. The ventral horn is really a type of nucleus, but it has a special name of ventral horn. You might recall that with our spinal nerves that the lateral cortical spinal tract is the primary innervation of upper motor neurons to the lower motor neurons. That lateral cortical spinal tract starts in the contralateral cerebral hemisphere in the primary motor cortex. It crosses at the bottom of the medulla at the spinomedullary junction in order to get to the ventral horn to innervate the lower motor neuron. If we lose the lateral cortical spinal tract on one side, we are going to have paralysis or paresis of the muscles on that side. But the brainstem has been protected. God knows how many important functions we have related to sustaining life in the face region. The throat, breathing, all of these kinds of things are very important. You have to be able to get air through the larynx in order to breathe. So God protected these vital structures. He did this by giving bilateral upper motor neuron control to many of our cranial nerves. These neurons start in the primary motor cortex, just like the lateral cortical spinal tract does. But instead of going down to the spinal cord, they're only going down as far as the brainstem. So they are called cortical brainstem tracts or cortical bulbar tracts. The anatomists felt that the medulla looked like a flower bulb, and that's why they called it the cortical bulbar, because it's going down to this bulb. But your book refers to it as cortical brainstem. It is the same tract. Because you have bilateral upper motor neuron control, meaning that both cerebral hemispheres send upper motor neurons to the cranial nerve on the right side of your brainstem, and both cerebral hemispheres send upper motor neurons to the cranial nerve nucleus on the left. That if I damage one of those cortical bulbar tracts, I still have the other one to tell the lower motor neurons in the cranial nerve what to do. And therefore, I don't see symptoms. So we're spared. Basically, again, God made it redundant, so we have some sparing. I do want to note that the extraocular muscles, these are the muscles that move your eyes around in their sockets, their lower motor neurons are not going to receive direct cortical bulbar innervation. They get innervation from different pathways. They often travel together, but they are different pathways. There's different parts of your brain involved, and I don't feel that you need to get into knowing and understanding those different pathways. So we're not going to go through them in the class, but I do want you to recognize that if you have damage to cortical bulbar tracts, that is not going to affect moving your eyes. So just kind of keep that in mind. We can rule out eye movement when we're looking at symptoms and talking about what kind of symptoms you would see. In this image, we can see the innervation from the two cerebral hemispheres to the cranial nerve nuclei. In the top picture, you see black neurons coming down from the left cerebral hemisphere and going to both the right and the left side of the brainstem. On the other side, you see a gray neuron that's coming down from the right cerebral hemisphere and is going again to both the right and the left side of the brainstem. So those nuclei, those cranial nerve nuclei that are in the brainstem, are getting innervation from both the right hemisphere and the left cerebral hemisphere. And they're pretty equally distributed. So you have equal amounts from the right hemisphere, equal amount from the left hemisphere, so that if we have damage to, in this case, the black neurons from the left hemisphere, those cranial nerve nuclei are still okay because they're getting good innervation from the right cerebral hemisphere. Nuclei that get good equal bilateral innervation with their upper motor neurons include the trigeminal nerve, the facial nerve, but I'm going to make a caveat here, only to the muscles of facial expression of the upper face. So we're talking around the eyes and the forehead and the scalp. Then we have cranial nerves 9 and 10, and cranial nerve 11, the accessory nerve. So they all get pretty equal upper motor neuron innervation from both hemispheres. Injury to one of these tracts doesn't develop into symptoms because those nuclei are still getting innervation from the other hemisphere. In the middle, we have the hypoglossal nerve, cranial nerve 12. Here, the upper motor neurons almost all go contralaterally. Only a few neurons are going to stay ipsilateral. So you can see when you look at the black arrow how it's thick going from the left cerebral hemisphere over to the right side of the brainstem, but it's very thin going to the left side of the brainstem. And the same is true when we're looking at the gray. We have a nice thick arrow going from the right cerebral hemisphere to the left side of the brainstem, but only a small little smidgy going, staying on the right side to go to the right side of the brainstem. If I damage one of these tracks to the hypoglossal nucleus, in this case, again, the black one is damaged, so the one coming from the left cerebral hemisphere, that means my right hypoglossal nucleus is only getting a tiny little bit of innervation from the brain, because all it has left is that little bitty gray. As a result, I'm going to see a significant amount of paresis on the right side of my tongue. That's what the hypoglossal nerve controls. The little bit I've lost to the left hypoglossal nucleus with that little tiny black arrow is probably not enough to show up symptomatically on the left side. So I'm going to see a significant weakness and paralysis on the right side of my tongue because my right hypoglossal nerve is not getting appropriate signals from the brain. Then we have the bottom picture. This is the lower face innervated by the facial nerve. So this would be muscles of facial expression around the nose, mouth, and neck. So you might recall platysma and zygomaticus major and minor and levator labii. Those muscles that are all around the mouth, across your neck, around your nose. This part of the facial nucleus only gets unilateral innervation from the upper motor neurons. So the upper motor neurons, the cortical brainstem or cortical bulbar neurons coming from the left cerebral hemisphere, only go to the facial nucleus on the right side of the brainstem. The gray coming from the right cerebral hemisphere only goes to the facial nerve nucleus that's in the left side of the brainstem. Because of this, if I have damage to one of those tracks, the one coming from the left cerebral hemisphere, that's going to cause paralysis of the lower face on the right side because those lower motor neurons no longer have upper motor neuron innervation. That is identical to what happens with our spinal nerves with damage to the lateral cortical spinal tract. Continuing our comparison of cranial nerves and spinal nerves, let's move on now to sensation. The somatosensation that is coming in through our spinal nerves, those cell bodies of those first order afferents are located in the dorsal root ganglion. When we're talking cranial nerves, the ganglion is named for the cranial nerve that the information is traveling in. They have special names beyond that. We're not going to learn those special names. So if it is somatosensation coming in the trigeminal nerve, we're just going to call that the trigeminal nerve ganglion, and we'll be good. Some special sensory also has neurons whose cell bodies are located within a cranial nerve ganglion, such as taste. Others do not, such as special sensory for vision. So I just want you to know, though, with sensation, again, it's the same as what we have with the spinal nerves in that for all of our somatosensation, with an exception we'll talk about later, the cell bodies are located in a ganglion, so outside of the central nervous system. Finally, looking at autonomic motor, You recall with the parasympathetics and the sympathetics at the spinal cord, their cell bodies are located in the lateral horn, or in a region analogous to the lateral horn. The autonomic motor neurons who are entering the cranial nerves, so these would be the parasympathetic neurons that are going to go into cranial nerves 3, 7, 9, and 10. Their cell bodies are located in a nucleus. Just as we can think of the lateral horn as a nucleus with a special name, there are special names for the different nuclei containing the cell bodies for the preganglionic parasympathetics up in the brainstem. So you can see the brainstem is actually very similar when it comes to somatosensation and autonomic motor as our spinal region is. Our cranial nerves have the additional special sensory piece, but it's the voluntary motor that is the most different as far as upper motor neuron control. Our cranial nerves, again, will have different combinations of the types of axons. Some of them contain all 4 types that we've discussed. Some only contain one of the 4 types that we discussed. Spinal nerves, we talked about, will have the sympathetic, the somatosensory, and most of them will have the voluntary motor, although not quite all. So there's not as much difference between different spinal nerves as we will see the differences between different cranial nerves. Again, only our cranial nerves can contain special sensory, and our parasympathetic axons are found only in certain cranial nerves, whereas those postganglionic sympathetics are in all of those named peripheral nerves. This is a link looking at the brainstem from a posterior view with the position and location of the different nuclei in the diagram. This is an image I came up with a few years ago, and I've modified it a little bit since then, that helps students to get a sense, or a better sense, of where the different cranial nerves are located in most dimensions of the brainstem. We can't get anterior posterior here, but you can get medial lateral and rostral and caudal. So starting up at the top, that first bump at the top represents our midbrain, our mesencephalon. Up there, very medially close to midline, we have cranial nerve 3 rostrally and cranial nerve 4 more caudally. So in our rostral medial midbrain, we have the nuclei for cranial nerve 3. In the medial caudal midbrain, we have the nucleus for cranial nerve 4. Then we go down to the middle bump. That's our pons. You can see that about mid-pons, midway there, maybe pushing up into the upper section, so the rostral section, but more laterally. It's not right close in the middle. We have cranial nerve 5, the trigeminal nerve. So its nuclei are going to be in that general area. Then moving down to the bottom of the pons, the caudal pons, things start getting crowded. Very close to midline, we have cranial nerve 6, abducens nerve. Just lateral to that, we have cranial nerve 7, facial nerve. Lateral to that, we have cranial nerve 8, vestibulocochlear nerve. Notice how I have the 8 straddling between the pons and the medulla. That is because cranial nerve 8 has 4 different nuclei on each side, 2 of which are in the pons and 2 of which are in the medulla. You're not going to know how those different nuclei differ from each other. I just want you to know that if there is injury to either the caudal pons laterally or to the rostral medulla laterally, that cranial nerve 8 is likely to be affected. Then moving into the medulla with the rest of the cranial nerves, we have, again, very close to midline, we have cranial nerve 12, the hypoglossal nerve. Laterally, we have cranial nerves 9 and 10, glossopharyngeal and vagus. But notice how all of these are rostral. So if I'm way down at the bottom of the medulla, these nerves should be okay. But once I start getting somewhere around midway, you can see I've got vagus nerve maybe just slightly above midline and up, then we're probably going to start interfering with these particular cranial nerves. And then down at the bottom under the medulla, because it's actually starting in the upper cervical spinal cord, we have cranial nerve 11, the accessory nerve. If you look at the cranial nerves that are very close to midline, so they're very medially located, you'll notice that all of those numbers are related to the numbers 3 or 4. So we have the number 3 and the number 4. 6 is divisible by 3, and 12 is divisible by both 3 and 4. That might help you to remember which ones are the most medial. Those are also the ones whose nerves are going to come out medially. Whereas the nuclei that are positioned more laterally, their nerves are going to exit the brainstem more laterally. The other thing I want you to notice is that I've drawn a line from the 7 going around the 6 and then heading out to the side to leave the brainstem. That is the motor neurons, the lower motor neurons for voluntary motor control from the facial nerve. Those neurons wrap around the nucleus of our abducens nerve. This will have impact when we're talking about an injury that causes damage to that nucleus of cranial nerve 6, in that it won't just cause problems with cranial nerve 6, it's going to cause problems with cranial nerve 7. If you have any questions on what this image is representing, let me know. But again, it's just to give you a quick idea of where the different cranial nerves are, which section of the brainstem. Are they midbrain, pons, medulla, or in the case of cranial nerve 8, both pons and medulla? Are they rostral or more superior in that section, or are they more caudal, more inferior? And then finally, are they located medially, close to midline, or are they located more laterally? To help with the anterior-posterior dimension, we would need to do a side view. This is an anterior view. If we were to do a side view, what we would see is that all of these cranial nerve nuclei are located dorsally. So they're all towards the back. So that's the end of our introduction to the cranial nerves. In the remaining parts of these lectures, we're going to go through the individual cranial nerves one at a time.